Pulmonary hypertension, which is defined as a mean pulmonary artery pressure exceeding 25 millimeters of mercury at rest, is an increasingly common diagnosis that without treatment portends a poor prognosis due to associated right heart failure. Multiple non-invasive imaging techniques, particularly echocardiography, computed tomography, and MRI, are used in the evaluation of patients with known or suspected pulmonary hypertension. In their paper in the March-April issue of RadioGraphics, Dr. Felipe Jaramillo from Bogota, Colombia, and colleagues from St. Louis, Argentina, and Chile review the current NICE classification of pulmonary hypertension, which groups patients into 5 categories based on pathophysiology and treatment options. The article then focuses on the use of CT in patient evaluation, which is the point where most radiologists enter the picture and play a key role in categorizing patients and helping clinicians guide further workup and therapy. The authors divide the chest CT findings of pulmonary hypertension into pulmonary arterial, pulmonary parenchymal, cardiac, and mediastinal abnormalities. Pulmonary arterial findings include vessel caliper changes, intraluminal filling defects, as might be seen in chronic thromboembolic pulmonary hypertension, and peripheral calcification. Pulmonary parenchymal findings such as centrolobular nodules are typically the result of cholesterol granulomas, but if widespread should prompt the consideration of pulmonary veno-occlusive disease or pulmonary capillary hemangiomatosis as the etiology of the pulmonary hypertension. Subpleural reticulation is most characteristic of chronic fibrotic interstitial lung disease, including idiopathic pulmonary fibrosis and fibrotic nonspecific interstitial pneumonitis. Mosaic attenuation of lung parenchyma is seen in chronic thromboembolic pulmonary hypertension, or CTEPH. Intralobular septal thickening and diffuse ground glass opacity are typically the signs of interstitial edema, as is seen in group 2 patients with pulmonary hypertension that is secondary to left heart failure. Cardiac findings, including left to right shunts, are seen in congenital heart disease, and there may also be signs of left ventricular failure as the etiology of the pulmonary hypertension. Mediastinal findings, particularly the presence or absence of bronchial arterial collaterals, helps in the diagnosis of CTEPH, which in contrast to idiopathic pulmonary hypertension is typically associated with bronchial arterial hypertrophy. The paper concludes with a summary table that lists by category the CT findings described in the paper and the associated subtypes of pulmonary hypertension seen with each of the CT findings. The paper can be found at the following link.